Good morning, good evening, good afternoon to all our participants from around the globe. I welcome you to the Anacapa Dental Implant Study Club. Today we have an outstanding speaker, and just to give you an idea of his commitment and dedication to implant dentistry, he's speaking to us at 4 in the morning. He's speaking from Israel. I'm sure many of you know what's going on in that part of the world right now. And I was expecting him to call me and say, hey, you know what, maybe I won't be able to do it, but he's up at 4 a.m. So I thank you very much, Mike, for doing this. So a little bit about Mike. He's a prosthodontist. He's a surgical prosthodontist. He's taught at the New York University College of Dentistry for the last 17 years, and he's had a private practice in New York also. He is a fellow of the Academy of Osseointegration, diplomat of the International Congress of Oral Implantology, and fellow of the New York Academy of Prosthodontists. I could go on and on and on. He's written many articles, many publications, but what I will say is that I've seen some of his presentations, and I was really excited that he would be presenting for us today because he has a very practical approach to implant dentistry. So without further ado, Dr. Michael Klein, take it away.
Thank you, Saj. I'd like to welcome everyone here this evening. It's a pleasure and an honor to present before you. I know that you have listened to a very august lineup of speakers over time. And Saj, I commend you on the study club because I think it's like great what you guys do. Just as a matter of disclosure, you've heard that I'm a clinically practicing prosthodontist, but I have a second job as well, as I am the CTO, the Chief Technology Officer, and the Medical Director of the Keystone Dental Group. So you can keep that in mind as I present my material. But I'll be open to any questions or any things like that you have at the end of the presentation, I imagine, Saj. Okay, so I have a lot to present, and so let's just jump right into it. And here's what I titled my presentation for today. It's called Change the Way You Think About Digital Technology and Procedures. Now, I know this is a group that I believe believes in technology, is interested in it. It's when, what, and how to create a useful digital workflow. We've all for years have been hearing about technology, and we've seen very innovative different pieces of technology and softwares. And the question a lot of us always have is, that's great and that looks exciting, but how do I make it practical? How do I make it work for me, aside from being just kind of some kind of like fancy or sexy tool that I have in my office? So I'm calling this the real digital revolution. And what I'm going to present to you today and show you here today is what I do every day in my office. These are our everyday office routines. So let's get right into it. Here's my goal. My goal is, when we're done in the next hour or so, is for you to open your minds and begin to understand the possibilities of digital technology. And we're going to do that by talking about new technology, new materials, new techniques, all with a goal of better outcomes, fewer treatment visits, less treatment time per visit, and also lower costs of treatment that we can then also pass on to our patients. So here are some of the things we're going to talk about today. We're going to talk about 3D printing during surgery for simplified restorative treatment. We're going to talk about a technique, the immediate zirconia provisional restoration. We're going to talk about what I'll call today the in-office dental laboratory. And again, I'm a prosthodontist. So for many, many years, I've had a laboratory with technicians in my office. But today with technology, I believe everyone has the capability and should have capacity to have a dental laboratory in their office without a staff of technicians. And by the way, that's not only for restorative doctors, but you'll see how this is applicable and why it should also be in the surgical offices, whether it's for periodontists or implantologists or oral and maxillofacial surgeons. We'll talk about a concept that I'll call the virtual technician, which, you know, that might be just a name that I'm using, but many of you already might be employing this type of technique. We'll talk about a technique that I developed, or really my partner, Dr. Alon Waltuck, developed, which is the creation of a screw access hole recovery guide, and how we did that by necessity, and you'll see in the case that I'm going to show you. And because of the technique we developed for this, that led to the use of low-dose cone beam CT for the creation of provisionals, or a simplified provisional. And then we'll talk about some you know, more basic workflows, like that would start from final impression taking at the uncovering visit of implants for implants that are buried, and simplified shortened protocol for restorative treatment. So there's a lot of different things we're going to talk about. Certainly not everything in the digital realm, but just I picked certain things that might get you to start thinking a little bit differently. Because to do all the things that I'm going to talk about and show you today, you need to start to rethink the way you provide patient treatment and rethink the way you sequence patient treatment. You see, technology wasn't developed just for you to go ahead and replace a simple tool, take a better x-ray, to avoid impression material. But it's to change the way we provide treatment to our patient, to change the sequence of treatment, and through that, provide better outcomes for our patient. So in order to do this, okay, we need several things. Number one, it relates to tools that record the relevant information to properly create a treatment plan or data collection. Tools to analyze the data to create a treatment plan. Tools to implement the plan that we've created. Okay, so we're talking about tools used to simplify surgical procedures and other surgical treatment at that time during the surgical appointment. Laboratory tools and techniques to simplify the restorative treatment during treatment, as well as restorative treatment, as well as during surgery. Now, when we talk about our tools and specific, let's call it hardware technology, I'm going to separate things in all these arenas, so the must-haves and the nice-to-haves. Today, I think everyone should have a must-have. I'll call it an intraoral surface scanner. Whether it's a Carestream, whether it's 3Shape, whether it's Medit, whether it's any one of the number of scanners. But I believe today that's a must-have. And you'll see it's not just to replace impression material. And then secondarily, I believe in terms of hardware is a 3D printer. And today, with the accuracy, with the efficiency, with the relatively low cost, okay, it's simple to put yourself into that position. And, you know, in my office, this is the printer that I use. It's from SprintRay. And I've gone through and had experience with, a fair number of different printers, whether that's InVisionTech or FormLab or Stratus Object. And I would say probably around 6+ maybe 7 months ago or so, we started using the SprintRay system. Here you're seeing it. I've actually got 2 printers on the counter there, along with their cleaning unit and their curing unit. It's a whole system, and I'll show you how that all operates. And I think this starts to bring it more into the realm of easy use in the dental laboratory, in the dental office, by your standard assistant, without having to have laboratory technicians to operate this type of technology. Nice to have, well, I'll call it a cone beam CT scanner, but if you're the one placing the implants, you know, then it moves into the must have, because I can't see any office today that's placing implants that isn't using cone beam CT technology. That doesn't mean you're not capable of placing implants to do that, with all the advantages and all the things that we can do with that data from the CT scanner, it's a must-have for offices that are surgically placing implants. 5-axis CNC milling machine, that's changed for me. I used to think that, let's say, if you asked me maybe, a year and a half ago, it might have moved more into the must-have, and it's moved now into the nice-to-have, because today I can do most things that I think should be done in the clinical dental office. Most things in terms of manufacturing technology can be done with the 3D printer. And sure, yeah, if you're going to make custom abutments, you'll need a milling machine. If you're doing more sophisticated laboratories, such as milling titanium bars, or you're milling your own zirconia, or you're milling glass ceramics, those types of things, then you need a milling machine. But I think probably most of us are not going to be doing that. And you'll see the things that I'm showing you are all things that are done with a 3D printer. And then we have facial scanning technology. And I think we're just at the beginning of learning really how to gain maximum use out of that. So I'm putting that in the nice to have category still, but I think fairly soon that's going to move in the must have category. In terms of softwares, must have, well, I have surgical planning software, and you see I wrote viewing. Why viewing? Because even if you are the restorative doctor, okay, you want to be able to go ahead and view interactively the implant position, not relative to where it's in the bone, but how you're going to restoratively go ahead and use that. And you may want to be able to impact on that position. And if you're the one doing the surgery, then for sure you should have surgical planning software. Nice to have, okay, again, is the interactive, being the ability to move the surgical planning software, prosthetic planning software for diagnostic wax up, restorative design. Again, you might be integrating with your laboratory or planning or planning service. And even if you're doing that, it's nice to have the prosthetic planning software because you have the ability to modify a plan that they've made. And again, the facial scanning software, like we saw before. Here, again, when we talk about surgical planning software, there are advancements in there. So here's a software, and it's called KeyPlan. And this is Keystone's version of ExoPlan from ExoCAD. And the reason I like this particular software is there are two versions of it. One's a full-fledged version to do all the surgical planning as well as guide fabrication. But then there's a basic version, and the basic version basically is completely functional, except that you would not make a surgical guide with it, but you can complete the design with it, which means you can send the data to your planning service. They can send you the plan back. You can view it in your own software, and you can make small adjustments. So instead of having to go into that team viewer that we're all doing with our laboratory or planning services and give them instruction, you can actually learn 2 or 3 basic functions, and you can, rotate the implant or make slight movements for the implant without having to go through complete planning. So this is a really nice piece of software for even people that are just doing restorative applications to go ahead and have to be able to go ahead and manage and maneuver those implant plans. In terms of clinical tools, okay, so if you're the person doing the surgical portion of it, you should be having a fully guided surgical kit because as you'll see through the presentation, I'm a firm believer in guided surgery, not because you can't do it without a guide, but all the advantages that you have with using it for a guide. And you'll see what we're talking about as we go through the rest of this next hour. And then you need to have intraoral scan abutments that are compatible with the implants that you're utilizing. And those implants that you're utilizing need to be digitally compliant, which means both the external geometries of the implants, as well as the positions of the connections. There need to be libraries of that in the planning software, as well as libraries of all the restorative components and components that we use for, let's call it digital dentistry, which are primarily multi-units and tie bases and custom abutments. So you need to ensure that the implant systems you have all of those types of components and parts and libraries that match in the planning software. Nice to have, okay, I'll put in that in ISQ measurement tool. What's that? That's Ostel, okay? I believe in predictability, like all of you do. That's what got us into, or brought us into, 30 years ago into implant dentistry, predictability. And we have predictability when we can do things objectively. So not only implement treatment plans, but implement the treatment, as well as objectively assess our results. And that's what I do with the ISQ or the Ostel tools, okay? I have a way of objectively assessing what I can do with my implant. Can I immediately load the implant? Is it time to put the definitive or final restoration on the implant? I can use that by measuring trends and looking at overall numbers with those types of tools. Now, again, for those of you that have already entered into the realm of digital technology, and for those of you that haven't but are looking into it, I'm sure you've heard the word open architecture. A salesman is going to tell you it's open architecture because today most systems are what we call open. So what does that really mean, that word open architecture? So here's I think the most simple way of explaining that. Open architecture means that the data that's collected from the diagnostic hardware, what's the diagnostic hardware? That's the cone beam CT or the intraoral surface scan data. That data can be accepted into the CAD software. What's that? That's the planning and design software, whether that's restorative or surgical planning software, which will produce a manufacturing file. We call that's an STL file that will be accepted and read by the CAM technology. What's the CAM technology? The manufacturing technology, which is 3D printing and basically CNC milling. That's the CAD technology, CAM technology that we currently use. Or does everything speak to each other? Does your cone beam CT data speak to your intraoral surface scan data and your planning software data and your milling machine? And does all of that work? Today, most vendors of software and hardware will say, yes, ours is open architecture. And then you purchase the technology and you try to make it fit together. And sometimes it works seamlessly, and sometimes you're banging your head against the wall. And so, I'll introduce to you here today the Keystone or KDG digital ecosystem. And what this is a system of products, hardware, software, technologies, implants, components, all that's been integrated together in an open architecture fashion, meaning that we've put these parts and pieces together that we know that work seamlessly, but at the same time, you can replace any one of these pieces with technology or softwares you already have in your clinics or offices, or that your laboratory uses, or that you'd like to purchase. They will also integrate within it. But within our system, we know that there's a seamless integration. So let's talk about the different components. So for data collection, right? We have cone beam CT, right? And intraoral surface scanners. That's where we collect our data, right? And so we have collaborations here at Keystone with Airstream for their intraoral surface scanning and Ray America for their cone beam CT. Well, once we collect the data, right, we need to do some planning and design. And I showed you, KeyPlan, which is Keystone's version of Exoplan from Exocad as well as Exocad software. And so that all integrates within that. At the same time, if you're not doing your own planning and design, right, so you can use a planning and design service. That could be your own laboratory, or it may be a planning and design service. And within our system, we have Full Contour and SprintRay Cloud Design that will do both surgical planning as well as restorative planning, or the integration of both, such as in a case where you're going to create a surgical guide and then have an immediate provisional, prepared for you in terms of that. Manufacturing technology, we have collaboration with SprintRay, and that's as well as with their hardware for printing and their printing materials for surgical guides, for models, for provisional restorations, for all those aspects. Then to make all of this work within Keystone for all the brands of Keystone, and Keystone has the Paltop brand, it has Genesis brand, it has Prima brand, it has Molaris brand, all their brands of implants all have surgical libraries in the major surgical planning softwares, such as, ExoPlan from ExoCAD, such as Implant Studio in 3Shape, such as Blue Sky, as well as restorative libraries. And again, the major planning softwares of, Dental Wings, 3Shape, ExoCAD. Integrating with that, we have fully guided surgical systems for the major brands of implants, for the Paltop brands, for the Genesis brands, for the Prima Plus brands. And we'll show you a little bit of that. We have new innovative designs of fully guided surgical systems, and those are integrated into the major planning softwares, as well as the digitally compliant components, which are basically scan bodies, abutments, and with the abutment systems, primarily, we talk about multi-units and their components and tie bases and their components, as well as milling blanks and specific analogs and everything that goes along with it, all so that we can produce seamless and efficient and accurate final restorations. So let's jump into some cases. I'm a wet-fingered clinician. I learned, probably like a lot of you do, I like to see cases. I like to see how those things work. I just said a whole lot of stuff. It may be meaningful. It may not be so meaningful to you, but let's see how it applies and how it works in actual clinical dentistry, and then you'll have a better feel for it. So let's jump right into a full arch case. Here's a patient who is edentulous in the maxilla. She's wearing a maxillary denture, and she has a failing mandibular dentition. And you see she's wearing an acrylic transitional partial. She's got a fairly large defect around that molar and the rest of the failing dentition. So what's step number one? Step number one is we go ahead and take our intraoral surface scans. We make our digital models, right? We're collecting data. Step number two, right? We've taken our cone beam CT scan. We've integrated the data sets within surgical planning software, selecting the positions to go ahead and place implants. Now, in my thought process in planning any of these cases, what's most important to me? What's most important to me is going to be, what's the final result going to be? And I don't want to compromise the final result for, let's call a provisional convenience in terms of that. So I'm going to decide where my implant positions need to be, where they're going to be placed, ideally, okay, for my, long-term final restoration. And then I'm going to work the provisional around that. So here we go. You can see there are going to be 5 implants placed. We're going to extract all the mandibular teeth, and this is going to be a, full arch solution, immediate load on these 5 implants. So here we go. I'm going to talk a little bit within this, the impact of treatment sequencing. So, I know most of you probably know about stackable guides, right? I think they're great systems, okay? I like them because of the whole sequence of treatment and how they operate. But I like to try and make things as simple and as easy as possible. And I'm trying to eliminate the portions of steps where there can be complications, either because things are more difficult or there's potential for error. So I know that number one, if I am going to use the surgical guide and I'm going to position my surgical guide, if I can put it on a fixed structure that exists in the patient's mouth at the time of surgery, that existed, okay, at the time of the CT, that's going to be my most stable and predictable guide position. So number one, I like to try and retain some teeth for convenience of the surgical guide. Number one, I have a secure surgical guide. I have predictability of implant positioning. I have an easier surgical procedure, and you're going to see how it lends to the ease or making an easier restorative procedure on this end. Because, not all of us do these types of cases every day. And we know that sometimes the restorative part can take longer than the surgical part, which can be a little bit frustrating. But let's see if we can change that. So here we go. Here's our patient, right? Here's their mandible. They've got those 1, 2, 3, 4, 5, 6, 7 teeth, right? And I've virtually extracted in the software 4 of those 7 teeth. And I've kept, you see, 3 teeth. I've kept 2 cuspids and a first premolar tooth. 3 teeth, and we'll explain to you in a minute, why I kept that number of teeth. I've kept those 3 teeth. I've integrated the CT with this, right, and planned my implant positions that are going to be where the implants are going to be. Now, from that, I can go ahead and fabricate my surgical guide, and my surgical guide is made to fit to those 3 teeth. So I'll have a fairly stable surgical guide on 3 teeth like that. But if you take a look at the implant positions, right, both right and left there, you'll see the proximity they are to those teeth, to the mesial of tooth number 22 and to the mesial of tooth number 27. Well, that circle or that pole that's coming out from the implant isn't touching the teeth, right? But what's going to happen? Take a look at my bottom picture with the surgical guide. The sleeve from the surgical guide, right, is going to, run into or impede and have a problem with seating of the surgical guide if I keep those teeth. Right? If I keep those teeth. And again, I don't want to reposition my implants just because I'm keeping teeth to position a surgical guide. Well, I can manage that. If I know that's going to happen, I just know that when I begin the treatment, what do I have to do? Well, I'm first going to extract the teeth that I plan for extraction, keeping these 3 teeth, and then I'm going to cut those teeth. So I'm going to go to those same exact positions that I saw in the surgical plan, and I'm going to cut the teeth so the surgical guide will fit, and I can keep those teeth. That much removal of tooth structure doesn't impact at all the stability of my surgical guide. I still have, look how many other surfaces I have that it's going to engage. The buccals, the linguals, the distals of those teeth, the occlusal surface. Excuse me. I have plenty of stability from that surgical guide. So I extracted those other 4 teeth. I kept the 3 teeth that were part of my plan. I seat my surgical guide, right? I perform my guided surgical procedure, right? I open my flap. I place my implants, right? And now I'm ready to actually begin my restorative procedure. Yeah, I've kept those 3 teeth. But I told you before, this is going to be an immediate load. We're taking out all the teeth. But I kept those 3 teeth, and we'll explain it in a minute why. I've placed multi-units, and I've placed scan abutments on the teeth. And if you come to this bottom left picture over here, I think you can see my cursor. You'll notice that, I put in a couple of sutures over here around these multi-unit abutments. And why did I do that? Because I'm going to go and take a scan now. And so when I scan, it's going to be easier to scan. I'm going to get a better scan if I don't have open flaps like that. I also remember when I'm scanning a mandible, right? I'm scanning a mandible, but I don't need to scan the whole mandible. I'm scanning for implant position. That's all I care about. And because I've kept those teeth, and because of the proximity of each of these implants to each other, I can relatively easily capture all that data. Going posteriorly, right, because I have minimal, fixed tissue, right, it's difficult to capture, but I don't need that data. All the data that I'm looking to capture here is my implant position. So I've scanned at this point my implants. Now what I do is I send this to my laboratory, or I send it to my planning service. In other words, I coordinate this with my laboratory. I send that data to them, and what they do is they are now going to take that scan and they are going to integrate it with a pre-surgical scan. So what they have in possession is the original scan that we use for our implant planning, right? But before any flaps were open, before the day of surgery. Why do I want that scan? Well, I'm going to talk about it in a minute, but because I've kept those 3 teeth, right, we can integrate these 2 scans. So the significance of keeping those 3 teeth was, number 1, easy implant positioning. 2, it was easy scanning. And number 3, the ability to integrate the scan that I've taken at surgery with a pre-surgical scan. Now, while the laboratory is doing that, right, I can cut those sutures, right? I can extract those 3 teeth, modify or manage the bone, however is appropriate for that case. Do any grafting that's required. Here you see I've grafted these sites with this, I believe, is bovine bone, the OCBS bone from Keystone, with cytoplasmic membranes. There are TrueFix tacks from ACE that I've placed there, and I've sutured the site. Now, I could have taken off the scan abutments, okay, traditionally, if they weren't on there, I would have put in multi-unit healing abutments and sutured around that. But instead of the multi-unit healing abutments, I just leave the scan abutments on, and I suture around the scan abutments, and that's going to create the space for my provisional restoration seat. While that's occurring, the laboratory is doing their work. So what do? Remember, they integrated the two sets, okay? They integrated the scan taken at surgery with the pre-surgical scan, okay? Now, why was that significant? Well, number one, that's giving me my overall or general soft tissue position. It's giving me my centric record and vertical dimension, right? Because the pre-surgical cast is already mounted. So I'm integrating this into a set of mounted casts, okay? What else is it doing? Well, on those models, I've already created a restorative design. I've already created the design of the provisional restoration. And because of the surgical plan that was created in the planning software, okay, pre-surgically, we've integrated that and converted that into a restorative master cast, okay? And that's what the provisional design was made on. So the implant positions are about in the same position, but about. When we've now gone and we integrate the actual implant position from the scan bodies, we have a corrected position of actual final implant position. So now what I've created is, or the laboratory has created is they've created a mounted cast, okay? A mounted cast of implant position with the abutments selected with already the final design of the provisional restoration. And so those two are integrated together, and all the laboratory needs to do is finesse the actual implant position to the anticipated implant position. Everything is already done. So this turns into a 15 to 20 minute laboratory process instead of an hour and a half or 2 hour laboratory process, because everything's been done in advance. Now, where's this design being done? I don't really care where that design's being done. It can be done by a technician in my office. It could be done in China for all I care. It doesn't matter. I've arranged it and coordinated so it's being done while I'm having my surgery done. Because then the manufacturing file, when that design is done, it's just sent back into my office. So it's sent back to my office 20 minutes later. And 20 minutes later, I have a manufacturing file that I can now go ahead and manufacture in my office while the patient is being grafted and sutured and finished. So let's go take a look at the manufacturing technology that I have. This is what I use today, okay? I use the Sprint Ray system. Here you see it, okay? Within that system, right, we have all different kinds of materials. What I'm showing you on the right is you see two different types of material. This is temporary material, and there are multiple shades, okay? And here is surgical guide material. And so today, most in-office systems, right, use systems where you pour this material into it, or I'll call it the goop, into that tray, and that's what you print. There's a platform, and it dips in and out of the liquid, and there's a UV light underneath it that cures it. And from the manufacturing file, it cures. And in this system, you can choose 55 micron or 100 micron layer thickness. Okay. For speed, we'll choose the thicker micron thickness, the 100 micron thickness. And for what we're producing here, we're not producing crown margins to teeth. Okay. We choose the 100 micron layer thickness, because I can produce this provisional restoration in about 35 minutes in this printer. And if I have multiple trays, I don't have to take the goop in and out. So we pour the material, we have as many trays as materials and shades that we have, and we just put in the appropriate tray, whether it's for a surgical guide or whether it's for provisional. Is it A1? Is it A2? Is it whatever is the shade going to go ahead and be? And then here within the system, we also have post-processing, a cleaning unit, as well as a curing light. And that's just simplified things, this cleaning unit, from the way that we used to do it by hand before. So if you take a look here, you'll see that here's the provisional restoration after 35 minutes, and you'll see there are two of them. There are two, and they're the exact same. Well, why do I make two? Well, it doesn't take any longer to make one than it takes two. It depends how tall this is. That's what dictates the length of time it takes to manufacture anything. So number one, if I printed two, if I somehow have a problem or I break something, along the way, I've already got a spare made. But aside from that, okay, gone are the days that I'm repairing patients' provisionals. If a patient comes in and they break a provisional, I've already got a spare in the box. I just put a new one inside their mouth in terms of doing that. The cost of this material, okay, is pennies, okay? It's very inexpensive. Even if you're using some of the more expensive restorative materials to go ahead and print in these printers. Like this might have been printed, I think, maybe in the Bego material, which is actually a designated for final restorations, for single crowns. But we'll use that material sometimes because it can be a little more aesthetic. Okay, so let's take a look and see how it works. So number one, you see here, let's look on the left. There's my partner, Dr. Woltuck. Okay, Alon Woltuck, and he's just going to remove now one of the printed provisionals. And he's just clipping some of the struts. You can take like a spatula and even scrape it off if you like to go ahead and do that, if you want to go ahead and do that. Or I believe you can even just put the whole platform inside this post-processing unit. So here he is, he's just clipping a couple, and he'll just then pull that off the plate. Okay, he's going to put it into the cleaning unit. Right, just put it in the basket, close the door, press the button, and off it goes. It takes, there are alcohol baths. You look at the next screen, you'll see here, well, next in the same screen, you'll see there's this alcohol bath, and you'll see it's going down. Why? It's going down because it's getting now sprayed into this unit. You can see it kind of bubbling because it's getting off any of the residue that's on there. Once that's finished, okay, once that's finished, it sucks out that, we'll call it dirty alcohol out, and it now sends in a clean alcohol. So it goes through 2 cycles. There you see it spinning through the second cycle. And once that's finished, you take it out, and this is how it looks. Excuse me. Okay, so that's how it looks coming out from the printer. You'll see there's a really nice interface. It tells you which cycle it's in, as well as the drying cycle. And if you want to save time, you can actually, once it finishes washing, you can go ahead and just pull it out and air blow it dry, and then put it into the curing unit. And again, nice interface, easy to use, gives you all the instructions that you need. And then that's what we need, because you know who does this? The assistants do this in the office with minimal training. There's very little, you see, that's all they need to know how to go ahead and do. It's not complex at all. Now, if you want to be a little more sophisticated, we're going here and now we're painting on the apron, and we're using a light cured mask that we're just going ahead and painting on there, and then we'll go and cure that. Okay, throw it back inside the curing unit for another couple of minutes. Now, what I'm showing you here is the way we used to do it and the way we do it today. Prior to this, we did this by milling a temporary, the anticipated implant position from my surgical plan. And then we put titanium cylinders on and we would cure it. And you see I'm managing those big holes. Well, today, what you're looking at the right-hand screen, this is basically the same exact design. You can see where now we've got holes printed exactly with the implant positions on. So now we're going to fix in place the titanium copings or the tie bases that fit inside. We've tried all different kinds of cements. What works for us best is powder liquid painting on a conventional acrylic. So we go ahead and paint on some acrylic around the titanium coping, and we seat it into place. And it's rare that we have separation of a titanium coping, once we go ahead and use this. So, you may have some cements that you found that work well for you. For us, regular acrylic powder liquid is what works, securing these in place. And here's what it looks like. The entire process, okay, from taking the scan, being able to deliver this to the patient, it's about an hour and a half. But instead of going and, going to the patient's mouth and putting on the titanium cylinders and curing 2 or 3 in and taking it out and curing more in. And it always takes longer than you think. And then only when that's done, the surgeon can go and finish the grafting and suturing and using a lot of manipulation inside the patient's mouth. We finish the surgical procedure while this is all going on, and the patient sits and waits the rest of the time, holding some ice on their face, but without manipulation of all being done inside the patient's mouth. And that's how the patient walks out. And this has been very effective for us in utilizing it this way. Okay, so let's take a look at a maxilla. So now we have a patient's maxilla. You see that that's failing. Take the intraoral surface scans, do a diagnostic wax up, making corrections to the occlusal plane, giving them posterior teeth, all the things that we know we need to do. Okay, we've integrated this now with the cone beam CT. We've done our implant planning. Created our surgical guide. Well, remember, I like to use fixed surgical guides, and yeah, it's a maxilla, and I can put in pins once I extract all, the teeth. Remember, there's fixed bridge work in this patient's mouth. But if I have a way of securing this, and if I can retain some of those teeth to secure this for some of the more complex implants, in this case, the angled posterior implants, that's what I'd like to do. So that's what we do for the posterior implants. So we make 2 surgical guides. We have a surgical guide used for positioning the posterior implants. Let's call them the 3 and the 14 implants. But we designed the surgical guide to sit on those anterior teeth, and those sleeves are not going to go in. And then we have a second surgical guide that we designed to fit on the soft tissue once that's on there, and we have a little less acute positioning, in terms of that. So it's simple for us to go ahead, especially if we're printing this. The additional cost is negligible to have 2 surgical guides. So here we go. We retain our anterior teeth. We place our posterior angled implants. We go and position our angled multi-units. We can do all of that before we even go and take out the anterior teeth. Once that's done, we extract the anterior teeth, put the second surgical guide in, deliver the implants, and we can begin finishing the case. Now, I put this slide on because, really there are 2 ways that people restore these cases. One is with multi-units, and some people go right to the head of the implant with a titanium cylinder or a tie base that goes right to the head of the case. I believe for multiple reasons, all these cases should be restored on multi-units. Number 1, when you're using the straight multi-units, there's no connection between your screw access hole to the connection of the implant. And so you move that seam away from that, number 1. Number 2, okay, think about the delivery of force, okay, to the restorative connection and what happens when you're splinting multiple teeth with tie bases or temporary titanium copings that are non-engaging. If they're not engaging, what's holding it in place? Well, it's sitting on the implant connection, but you have the screw that you're engaging that with that's accepting all the lateral forces and excursive or protrusive movements. And so, why do I want to do that? I think there's a much better delivery of force to the restoration by breaking it up, by going ahead in the use of multi-units. And it's a much easier and more convenient restoration to go ahead and make. So the multi-units are placed. And again, I'm going to follow the same procedure I showed you before. Here, we couldn't keep any of those teeth, right? Because they were in a fixed bridge. They all had to be removed, but it's a maxilla. And in the maxilla, we can use the Ruge to integrate the data sets. So you see we've done the same thing. We've quickly sutured through a few sutures in to close the flaps. It makes for easier scanning. And when we've done this type of scanning, what we've done is we've taken a scan, again, on the day of surgery, even before I've extracted the teeth, okay? Before I've extracted the teeth, we've removed the teeth from that scan so that when it comes time to do the scanning, all we have to do is pick up the implant positions. So we've simplified the scanning procedure by, while the patient's getting numb, doing the first scan. Now, this is sent immediately to the laboratory, okay? And the laboratory can be working on the provisional restoration design. And at that time, again, we do our grafting, we do our suturing. And again, instead of placing multi-unit healing abutments, we go ahead and put on scan abutments. Now, they integrate the data sets the same way as we did before, but here they use the Ruge, integrate the actual implant position to what the planned implant position was. And on that planned case, we already have our final restorative design. So all they're doing is finessing the actual implant position, okay, through the provisional restoration. So again, a 20-minute process, and it's sent back. It goes into the printer, it's printed, again, about a 35-minute printing. This is more of a crown and bridge style restoration. And again, we cement the tie bases with our acrylic, and we've glazed the restoration and insert it inside the patient's mouth. So again, from start to finish of the restorative section meaning taking the scan, sending it to the laboratory doing the integration, sending it back, okay, after approximately 20 minutes, printing of 35 minutes, and the post-processing, meaning putting it in the cleaning unit, curing it, removing the struts, cementing the titanium copings, which can all be done by a dental assistant in your office, okay, hour-and-a-half process, and within that hour and a half, you're finishing the surgical procedure. Remember this, ideal scanning conditions are a clean and dry field, okay? And when you're in surgery, right, it can be a little bloody sometimes, well, but if you go ahead and suture those areas, you can go ahead and clean it dry and have it a little drier. Fixed, non-movable tissue, the more you have of that, the easier it's going to be to scan. That's why maxillas are easy to scan than edentulous mandibles, and close implant and or abutment proximity. That's why you saw in that first case, by keeping those teeth, aside from the other conveniences of stabilization of the guide and integration of data sets, right, it also made for easier scanning. So keep that in mind when designing your cases. Let's move something to something a little bit smaller. Okay, so here's a patient who had congenitally missing laterals and cuspids, and on the patient's left side of the mouth, you see that the lateral root's completely resorbed and the cuspid's on the way there. The plan was to extract both that primary lateral and cuspid and position and place the implant, and we were going to put a provisional restoration instead of immediate loading because the final design was going to be, a cuspid-based, implant retained restoration with a cantilevered lateral incisor. There's not enough room there to go ahead and place two implants. And so we get our tools ready. What are our tools based upon the plan? It's going to be the surgical guide, okay, as well as the provisional restoration. And all of this is fabricated from the two data sets that we get at the time of consultation, cone beam CT, as well as control surface scan. And my staff does all that. I don't do any of that, okay? And so here we go. Here's our design of our provisional restoration. No reason to immediately load this case. We could just quickly bond in a printed provisional restoration. And there you see the design, provisional Maryland bridge. So in the surgical procedure, we extract the tooth. You can see resorbed root, seat the surgical guide, place the implant, and simply cement in the provisional restoration at that point. Now the patient's saying, hey, wow, okay, I know the color isn't exactly perfect, but I need to do something about my other teeth. And now we have to start, the other lateral, contralateral, lateral, and cuspid, we have to start making decisions about now actually redoing the patient's entire, let's call it anterior aesthetics of his maxilla. So I showed you that kind of almost bring you into this next case. So here's a patient, she's 17, 18 years old, I believe this girl, okay, congenitally missing a lateral incisor tooth, and she's been wearing a bonded provisional Maryland bridge, and she's ready to have our implant placement. And it looks like she has, enough space there to go ahead and place a narrow diameter implant. And so let's take a look at our cone beam CT, right? There's that space, and we start to notice some things, and we even can start to see things when we start to look at her periapical X-ray. One of the things when I look at positioning implants in tight spaces, I like to do it by looking and paging through axial images. And when we look through this, we see, the peroneal ligament space isn't so clear, and even the laminate derma isn't so clear. Exactly where does that tooth, end? That looks like, the safe space that I have. Not only that, take a look. If you take a closer look at the periapical X-ray, that root on the cuspid, right, it dilacerates. It goes and curves into the space, making the space actually smaller in that area. So let me just go ahead and define that for you. There you go. That's the shape of the root on one side. There's the shape of the root on the other side. And so that's the space, and there's the trajectory to go ahead and place the implant. The Problem isn't at the coronal section, it's at the apical section. And the whole purpose of placing an implant is to have, conservative treatment, not to damage the adjacent teeth. So let's take a look. Now I'm going to show you another picture, okay? Looks almost like the same exact scan, right? But it's taken at two different settings. This is taken at the endo setting as opposed to the conventional setting. Look at how much clearer it is. And the machine that I use is the Alpha Scan from Ray America. So this is on their newer machine that I have now. And I say, wow, it's crystal clear to me now exactly where I can place that implant. And so let's go and page through these images. And so if I page through the images here, whoop, let's go back. If I page through these images, you can see the parallel ligament space is crystal clear, and I can see exactly what my position is. The outer green line, by the way, is the safety border. This is an implant studio, and the inner squiggly line, that's the actual implant position. And I can page through to the apical portion of the dilaceration of the cuspid root and ensure that my implant position is not going to go ahead and damage the tooth. And then I can design my surgical guide based upon that. Well, what about the radiation exposure to the patient? So let's take a look. So here, this is the machine that I have, RayScan Alpha Plus. And if I do this in the endo setting, right, what's my radiation dosage? Here it is. It's in microsieverts, 72 to 171 microsieverts, as opposed to a full scan, right, on the same machine, that's about 341 microsieverts. So what does that really mean? So let's compare it to things that we kind of today. So you've all probably seen things like this, okay? But let's put some numbers that make sense here. 100 microsieverts for radiation you see during a dental X-ray. A woman that gets a mammogram, 3,000 microsieverts. The lowest yearly dose likely to link to increased risk cancer, 100,000 microsieverts. They were talking about 70 microsieverts, not to cause damage to the roots of the adjacent teeth. I think that's an acceptable radiation exposure for the patient. So we have our surgical guide created. It's going to be a Paltop dynamic implant that's 3.25 millimeters in diameter, right? We've opened the tissue, positioned the implant. It's a congenitally missing tooth, so the implant position is almost going to always be subcrestal, right, at these positions, right? I'm not positioning my implants relative to where the bone exists, but relative to where the restoration is going to be and the emergence profile I need to create. And so you'll see with this here now, if you see I put the scan abutment on, that I've gone ahead and carved out a parabolic architecture so that I can develop a really nice free gingival margin. But in this case, I'm taking an impression at the time of surgery, not because I'm printing a provisional restoration right now, I could have, but it's when I go to uncover the implant or I go to restore the implant, I can just screw in the provisional restoration. For the extra 5 minutes to take the scan, I saved a lot of time later on. And here again, we're just going to put the patients, we just put a healing abutment on and put the patient's provisional restoration back inside their mouth. And if we take a look at our implant position, right, and we look at that, the tip of that cuspid coming in, we can draw it. We can see that, we put the implant exactly where we needed it to be, right? And that's because we were clearly able to define where the root of that cuspid was, not to interfere with it, right? So we have a safe position, and appropriate treatment for our patient. Now, again, we talked about before the concept of stack guides. Here's a patient that I had the opportunity to treat. She had a previous failed implant case. She was sent to me, and the treatment plan was to go ahead and place 6 implants in her maxilla, use a stackable guide type of case to go ahead and immediately provisionalize her. And in these cases can be fairly effective. But there are certain things about these types of cases that I don't like, and I think there are sometimes simpler ways to do it. This can be a very effective treatment, in some clinicians' hands for some patients. But I say, I believe, at least in my practice, there's still room for sequential extraction strategy. Not every case has to be immediate load, but can I program it just like that case was programmed? Can I digitally program it to simplify the treatment? So this patient was going to be losing all of her maxillary teeth. And the treatment plan was going to be to go and place 4 implants where our existing teeth are, and at the same time do bilateral sinus grafting for this patient. And now the question becomes, okay, how are we going to provisionalize her? And that's by keeping these 3 teeth, 2 cuspids and 1 lateral incisor tooth. So I started saying, okay, how can I start to go ahead and use that program approach to go ahead and simplify this treatment in terms of provisionalization for the patient? So here's our plan. Plan was that we would take the patient, and on the first treatment visit, okay, we did the consultation, first treatment visit, what do? We take those 3 teeth we were keeping and we prepare them. So we prepare the 3 teeth and place the provisional restorations on those 3 teeth. So an hour of treatment, okay, tops an hour of treatment. And we take a digital scan, right? No more than an hour to go ahead and do that. So there you see our digital scan. Now that goes to the laboratory, okay? The laboratory now takes that scan and integrates it with our cone beam CT with our implant plan. And we adjust the implants as we need to for that case. Then once that's done, we virtually extract all the teeth that are going to be extracted. So we see the implant positions, okay, along with the 3 retained teeth that are going to keep the provisional restoration. Now, the laboratory will go ahead and design the provisional restoration. The patient liked the way her teeth look, so we just had the laboratory replicate the design. There it is. So the design was going to be to go ahead and have this provisional retained on those 3 teeth and cantilever 2 teeth off the distal. There they are. Now, conventionally, before we were doing this, what would we do? So we wouldn't have a fractured or provisional constantly fracturing with those types of cantilevers. We would have a cast metal reinforcement placed within it. And so that starts to take us out of the digital realm. And I want to try and do this efficiently and cost effectively. So I said, you know what? Why not make it out of zirconia, right? And reinforce it, make the zirconia thicker in certain areas. But at the same time, I said, if I need to adjust it, it's not going to be so simple in the zirconia. So I took the same exact manufacturing file and I had the laboratory mill me a PMMA provisional. So that was in my milling days. Today, I would just print it out of that same file. So I had the same exact provisional, one in zirconia, one in acrylic. So here's the patient, okay? She's ready for treatment. Number 1, I go ahead and we do the sinus grafts. So we open the sinus windows. I haven't even anesthetized the anterior, right? And I'm going to open both sinus windows, graft them, and finish the sinus graft procedures. Now, once the sinus graft procedures are completed, I am now removing the provisional restorations on those 3 retained teeth. Remember, I prepared 3 teeth and put individual temporaries on those 3 teeth. So I removed the provisional restorations. Now I extract the anterior teeth, and you can see, why these teeth needed to be, extracted. They had resorbed roots. They, not viable teeth to keep for any type of restoration. So here's what I'm left with. I've grafted both sinuses. I've extracted the teeth that require extractions. And it looks just like my virtual model, right? That's what was planned. It looks exactly the same as it should. There's my provisional restoration design, right? It's going to seat on those 3 teeth. And there's my zirconia provisional. So now I kind of hold my breath. I haven't done my implant procedure, but I want to see how easy or difficult is my restorative procedure going to be. And so I go and I try in my provisional, boom, my restorative treatment is done. That's it. So I spent 1 hour in a visit before this preparing 3 teeth and putting provisional on. And that's it. And now, I have a provisional that's ready to be inserted at the time of surgery, simply and easily. And if I was coordinating this with someone else doing the surgery, I could just hand this over to them. So there's our now surgical design. We have the surgical guide made to fit on the existing teeth. So this is from the same data files, okay? I see color sleeves. That goes along with integrating with this particular fully guided system and the length of drills that are going to be used. And again, I have now a surgical guide that seats securely on teeth and not on soft tissue. Now we're using the fully guided system that I designed along with the engineers at Paltop or Keystone, and this is contra-angle based surgical guidance. And that's a topic for a whole nother lecture, but it solves many of the issues we have of conventional surgical guide systems. Okay, both with irrigation directly on the drill at all time, no drill flutes cutting or touching metal, leaving any flutes or shavings of metal. Along with that, as well as managing interarch space very effectively. I like to put guide pins in, even though this is done guided, to verify my implant position and for me to understand that I'm at the correct depth for where I want it to go ahead and be. And then I go and deliver the implants to position. And these are, again, Paltop dynamic implants. So a fully guided technique. Now, the case is there's some final grafting done, suturing. And now we're just putting some cement. I use polycarboxylate cement, Duralon for these types of restorations. But there it is. My restorative aspect of it is just cementing provisional into place. And so I've removed that entire element from the day of surgery. And there's our result, as we should expect on the day of surgery. And we all know that with proper planning and proper stabilization of the surgical guide and implementation of the technique, we have, we end up with very predictable implant positioning. But this was 3 appointments. Number 1, collecting the data. What was that? That's the intraoral surface scanning cone beam. Appointment number 2, we prepare 3 teeth. And appointment number 3, we do the surgery, all the surgery, and insert the provisional restoration. This is a technique that I've had accepted for publication in Compendium, and I believe it's scheduled to come out towards the end of the summer. Okay, so here's a patient that was seen by my partner, Alon Woltok. I wasn't in the office at the time. Patient came in. She had an implant treatment, not in our office, but somewhere else. So maybe 15 years prior. I don't think I would have placed the implants where they were placed. But who's to argue with 15 years of success? When the patient walked in that day without an appointment, the bridge was, hanging loose inside her mouth. She couldn't talk. She couldn't function. She had fractured implants. She had fractured abutments. And she needed some type of immediate solution. Now, this is a day that there was no appointment. There was no time to see this patient. So my partner kind of took some pity on her. Right? No, we treat patients. These are people. And so he squeezed out a half hour in the morning. He took out the broken parts and pieces. Okay, made sure there was some multi-units. He went ahead and put on some scan abutments, right, and took a scan. That was the data he collected. So he squeezed out about a half an hour to go ahead and do this. And so here's what I'm going to talk about, the virtual technician, which really is just, being coordinating with a planning service. So he took that data and he sent it to the planning service or the virtual technician, or it could be your dental laboratory. You need to develop this type of relationship with your laboratory. So it's sent to them. They then went and created provisional restoration design. So this now can become an hour and a half, 2 hours of work on the behalf of the laboratory, okay? So they first have to create the design, and they send back the manufacturing files, right? The design files to our office. So, he saw the patient 9 o'clock in the morning. By 9:30, the data was at the laboratory. At 11:30, was back in our office. At that time, we weren't printing these, we were milling these. So this is my almond garba motion to milling machine, and we milled out this restoration. It took about 2.5 hours to go ahead and mill. In my printer was 35 minutes. Okay, but again, relatively simple to go ahead and do. And then by the end of the day, the patient came in and we just inserted this fixed provisional restoration. So we inserted a full arch fixed provisional restoration where we only had a half hour of treatment time in the morning and, just delivery time at the end of the day. So we scan in the office, we design in the dental laboratory, we manufacture in the office, and insert in the dental office. And in this way, we can have what I'll call full arch resolution. Now, it's not the most beautiful full provisional restoration. There were certainly limitations to this because of where the implants have been previously placed. But the patient was able to go out and function, you know, at the end of the day, and go on with her life. And these are the types of things. Here's how we should be starting to think about how to alter our protocols and relationships, you know, with our laboratories, how we're going to do this. So every single office can have a dental technician in it without having a dental technician, by having a planning service or a relationship with your laboratory where they can do planning for these types of services, you know, for you. So if we go and look something with that concept in something small, conventional treatment, failing bridge, okay, failing bridge. We go and we take our two data sets, integrate them together, create a plan, right? So we cut the bridge, extract that tooth, and place 3 implants. These were buried at the time because of the grafting that I wanted to do at that site. Now it comes time to uncover the implants. Big broad band of keratinized tissue, okay? You know, I'm not a big or in favor or advocate of flapless surgery, but when you don't need to manipulate the soft tissue to your advantage, such as correcting a concavity, or we're not worried about losing necessary keratinized tissue, you can do things flaplessly. And here's by simply taking the patient's surgical guide that was used to place the implants and putting the trephine that's being guided through the surgical guide. So we've trephined directly over the heads of the implants. And if you look at this picture here, we can't see the implants. There's bone covering all these implants. You know, normally to do this, we'd have to go ahead and reflect a big flap. So we can just remove the overlying bone, right? There's minimal trauma to the soft tissue, which means what? I can select my final abutments, multi-units. Remember, I told you multiple implants. I like to always go ahead and restore them with multi-units. And so I can place the multi-units and scan all on the same day. All in the same day. So I'm not worried about the trauma to the soft tissue and where that soft tissue margin is going to end up for my final restoration. So appointment number 1, for me, that's the appointment that the implants were uncovered. We're selecting and placing our multi-units, right, and inserting them. And at the same time, we're taking our final impression, okay? So we take the final impression. Now, at that point, that gets sent to the laboratory. The laboratory creates the design for the final restoration. But instead of me getting a final restoration, I get a try-in. So I get that made in, this at the time was being milled in PMMA. Today, I would just print it. So what do I have? I have a mock-up of the exact design of my final restoration. I can evaluate and assess my contours to the soft tissue, my embrasure spaces, my contact points, mesial and distal, my occlusal contacts. I can make any adjustment or modification that I need, okay, so that this can then be converted into a zirconia restoration. And I know exactly how it's going to fit. I know it's going to seat passively. I know my contacts are correct. I know my occlusion is correct. Now again, today, if I was willing to keep the patient in the office 45 minutes, this could be 2 appointments, because I could uncover the implants, place the multi-units, take the impression, send it to the laboratory, have them create merge the design, okay, to the anticipated implant position, okay, and then I can print it and I can try it in so that on the second visit, my final restoration goes in. But today, there's no restoration I make without having a let's call it a real mock-up of what the final restoration is going to go ahead and look at. So this becomes either 2 or 3 appointments, depending upon whether or not you have the patient wait for that mock-up. And then this should be everyday workflows, and this is what we go ahead and utilize. So we had a patient, and this patient had a number of implants placed, maybe 10 to 15 years prior to this, and an excellent restorative dentist made them this really nice restoration. But the implants were failing, okay? These implants were failing here in the anterior, okay? You can see there's no bone on the buccal of those implants. But look at the restoration. This is a zirconia restoration. This was made at least 10 years ago, okay, where it's screwed down on top of the implants, but then there are Emax crowns made to fit to the zirconia restoration, cemented. So there are no screw access holes. This is cemented basically to the framework that's screwed onto the implants. How do I get there? It's 20 millimeters tall, okay? Am I gonna start cutting this apart? What am I gonna spend use 300 drills, burrs, and and a half a day or a day to get this out of the patient's mouth? So my partner, along Waltuck, he came up with an idea and he said, you know what? I can find those screw access holes. And here's how he did it. We took a cone beam CT. In the cone beam CT, we see exactly where the implants are. We put it into our implant planning software and then overlay implants on top of the implants that are actually in the patient's mouth. We can exactly position implants over those implants. See, there they are. Then we integrate the intraoral surface scan of the restoration with the cone beam CT. Now they're one file. So now we end up with a picture like this. We can see our, what normally would be anticipated implant positions, but here they are real implant positions with the restoration. And we put on the extension function, and we see exactly where the screws are going to be, right, that are underneath the Emax crown that retain the zirconia restoration to the implants. Now we create a surgical guide, except it sits on top of that restoration. So there it is. We don't need to put any sleeves inside. Print the surgical guide, or we'll call it the screw uncovery guide. There you see the provisional restoration. And you'll say, yeah, today I think I could have done a lot nicer, right? But remember, this is 10 plus years ago that this restoration was made, okay? Seated on top of the restoration, and now cut holes exactly where I know the screws are going to be. So I don't have to destroy this restoration. I can simply go those areas exactly where the implants are, access those, and then unscrew the restoration. And then this restoration can also become the provisional restoration while additional treatment is being done, right? So we can remove the entire provisional without destroying it. And any place we went through an incisal edge or the buccal, we can go ahead and just repair that with composite, and the patient can function. We can keep some of these implants as we remove some of the other implants to do the treatment. And so here you can go ahead and see that we can very accurately get to those implant positions. Now, once we did that technique, we said, hey, we can start to apply it to other types of technique. And I know I ran over, but we're going to finish up here. So here's a patient, right, who you can see is wearing a maxillary denture. They're edentulous in the maxilla. They have 2 failing teeth in the mandible where they had a partial denture. And you can see that they're in a severe class 3 relationship, okay, between their maxilla and their mandible. Now you can kind of, if you look now at the maxillary picture, you'll in the top left-hand corner, you can now see that's a significant class 3 relationship. So we're going to go ahead and put this patient into fixed restorations and correct that class 3 relationship. So number 1, okay, and I'm not going through everything the case. First, we obviously did diagnostic setups to reposition the teeth, giving them appropriate lip support and incisal edge position, where we wanted those, teeth to be. We created our surgical guide and placed our maxillary implants. At the same time, we did the same thing with the mandible, created a surgical guide based upon diagnostic setup, and placed our mandibular implants. And again, these are Paltop dynamic implants. In the maxilla, the patient was wearing a denture and was satisfied to wear a denture, so we buried the implants. In the mandible, they had a transitional, they had actually a partial denture that was retained by those 2 teeth. I didn't want them to put them into a complete denture, so we immediately loaded the implants that were placed in the mandible. Now, 4 months or so has gone by. We're ready to uncover the maxillary implants. And instead of uncovering the maxillary implants and placing healing abutments and then coming back and taking impressions, I want to start moving the procedure along. Okay, so I want to put him into already a fixed provisional. I want to uncover those implants and put a fixed provisional in place. How can I do that most effectively? So I said, let's use the same technique that we use to find those implants to create those screw access holes. Let's go ahead and use it as an impression technique. So I'll introduce the concept of using low-dose radiation from your cone beam CT to create a virtual model of implant position, right? For let's call it a provisional restoration design. So here you see, this is the low-dose setting and images that we get from the cone beam CT, and this again is from my RayScan Alpha Plus machine that I go ahead and utilize. And so let's go and say, well, radiation for an impression. So let's go back to the chart. Okay, let's go back to the chart. Remember, the endoscan we were at 72 microsieverts. For a regular full scan we take for surgery for a full arch, we're 300 plus or so microsieverts. Low dose, 38 microsieverts. 38 microsieverts. That's a fraction of an X-ray that we're going to go ahead and utilize that. So here we go, okay? We take our low dose radiation, okay? And we use the same technique. We put this into our implant planning software, we overlay implants on top of those exact implant positions, and we create an implant model from that. We then take that implant model and put it into the restorative design software. We integrate that with our diagnostic setup, right, to our implant positions and our restorative options, and then we finish the design, right, for our provisional restoration to the implant positions. But again, these are not accurate. I'm not going to be able to put a titanium coping inside here. What I can do is I can make something that's fairly accurate to the implant position. So there we go. This has been printed in our Sprint Ray printer, painted with our flowable, light cured masking material. And you see we have holes all the way through, but in, fairly close implant position, because we don't want to be fighting with the provisional to get it to fit on these 6 implants. So we uncover the implants, place the multi-units, right? Now I've placed the titanium cylinders and I've placed these nice aprons. And really what it is pre-shaped rubber dam material. But you can go ahead and you can just get these from Keystone. They're right in the catalog. It's easy. I put the multi-units on, I put the titanium coping on, and I just slide on, because the hole's already made in it, these aprons. I try in my provisional to make sure it seats passively. I do one side at a time, okay? One side at a time, because unless everything is completely, aligned, right, you're not going to have a good path, easy path of draw, okay? I put some dual cure composite around the titanium copings. That's why I have the aprons on. I don't want that material to flow into the undercut of the cavity of the multi-units. Seat it to place, light cure. Remove the provisional. Here's what you see: the aprons coming off with it. Okay, and now I can go to the other side, because now again my path of draw will be easier because it's not to the end of the titanium coping. It's from the end of the titanium copings on one side and the cylinder connection to the implant on the other side. So I seat them, and you can see I don't have to go ahead and be cutting these openings and getting it to fit. I have a position that's fairly, accurate and close to my cylinder position. I put in my little, cotton swab applicator tips. I inject in my dual cure material, and I cure and finish the provisional restoration. Now I put on here, you see the multi-unit healing abutments, okay? Before, in the other cases, at the time of surgery, I was showing you the scan abutments, but here we're not scanning today, okay? So I put the multi-unit healing abutments and can suture around that while this is being finished in the laboratory. Okay, and really there's minimal finishing to go ahead and do this, and it's inserted inside the patient's mouth. And you can see we're probably up to maybe an edge-to-edge, relationship here, which is not really what I want, okay? And I'm thinking, okay, but I can actually shrink down the overall arch circumference of the mandibular provisional, right, and put him into a normal class 1 type of relationship. Now, the patient comes back 2 weeks later, right, and I say, we're a little off, okay? Look at that incisal plane. We need to correct that. And at the same time, I want to correct the occlusal relationship. I want to put him into that class 1 relationship. Because it's in this provisional state, I want to know exactly what it's going to go ahead and look like. So we redesign the provisional restorations. This is for the maxilla. This is shrinking down the mandible. They would not be 2 different times, which is why the masking material is a little color. There you can see the healed tissue, nice big broad bands of keratinized tissue around all the implants, and we insert the new provisional restorations. Okay, now we've gone and kind of hit a home run here. He's happy with the way it looks. We've corrected the incisal plane position. We corrected the occlusal relationships within this. Now this can be replicated, right? And we've, go right to our final restoration at this point. This is actually monolithic, zirconia restoration that we have made for him and finished the case. We're still finishing actually the mandible now in the same fashion. So here's the finished case. So technology requires a new way of thinking and doing things, but it results in enormous patient and doctor benefits. Okay, I can do things in a way that I couldn't do them before that I think gives tremendous benefits to the patients, such as time efficiency, reduction of the number of treatment appointments, reduction in treatment time during appointments, reduction in time in between appointments, simplified and comprehensive data collection, simplified and comprehensive evaluation and diagnosis, easy multiple diagnostic try-ins. At the same appointment, I can have, multiple designs of a restoration, okay, that I can try in the patient's mouth, right? If there are different considerations for aesthetic reasons, the way I want things designed. I've reduced laboratory costs, and I'm not suggesting in any way eliminating the dental laboratory, but just developing a different relationship with them that eases along and moves along patient treatment. So you see most of what I do is in the provisional stage. When it comes to the final stage of restorations, most of that's being done, by my regular laboratory. And a virtual technician in every office. That can be a planning service. That can be a relationship with your laboratory that you currently, have to make that all work. Okay, but to gain the benefits of technology, we need to start thinking differently. We work in data sets, and I know it's not what we're trained to go ahead and do, but if we have some basic understanding of that, we start to understand how to develop new workflows. Now, I've just shown you some of the things, but this is everyday dentistry in our office. And this is the way we manage, patients on a daily basis. And we're able, I think, to provide very effective treatment in a more streamlined fashion, and actually a significant lower cost to us. And in turn to the patient, it returns over to the patients. So we can treat more patients and provide, better service to and quality of life to all of our patients. So, I'd like to thank you for your time and attention. I've run a little bit, over. I'm happy to answer questions, or if someone wants to ask a question and wants to write me, there's my email. That's, mklein@keystonedental.com. I thank you for your time and attention, and I turn it back over to you, Saj.
Thank you very much, Mike. I really appreciate your efforts and your time. And I know still 5-something in the morning over there. I do have a couple of questions if you have the time that have come in through the chat. So
I'm with you. The sun's coming up. All
right. So the couple of questions is, how strong are your printed immediate load provisionals?
So that's an excellent question. And, I'll give you the sense of it is, and I'm going to make a comparison to the milled PMMA. Our sense is the milled PMMA, is stronger, okay, than the printed provisionals. And what we'll actually do is because of that, we've moved to a lot of these to the Bego material, which is really, let's say, clear to be a final restorative material for single crowns. Now it's more brittle, actually. If you drop it on the floor, it can break, which is why I print too. And I think you need to have adequate support. You need to do two things. Number one, you'll notice, I'm not a big all-on-4 person. I may use that kind of style, but I'm putting more implants in and giving more support, less unsupported sections of implants, and I'll minimize the amount of cantilever I have. But I may also take that into account in terms of the design of the thickness of the restoration. So I may go ahead and create a thicker restoration on the lingual or palatal to, to help support the more brittleness of the provisional restoration.
So second question is, in terms of your workflow, where you place, you scan, send it to the lab prints. In terms of time, how much time does that take? Say, for example, you are placing 6 implants in a maxilla and you are sending the scan to the lab and you're waiting for the lab to send it back. How, from start to finish, from the scalpel to the delivery of the provisional, how long does that take you?
Okay, so I'll jump to the point of of the restorative phase of the section. Because the first portion of the procedure, you know, that can turn out to be, let's say, it could be an hour and a half, like let's say an hour and a half of time or so. Okay, patient's anesthetized, we're extracting some teeth, we're placing some implants, especially if I can retain, you know, teeth to go ahead and secure provisional restoration. It goes much, you know, much faster usually, you know, those cases. So let's an hour and a half of time, do the extractions, do the debridement, you know, depending how significant that is, place the implants, put on the multi-units. Okay, now the multi-units are on. So now if we start the clock then, where we're putting on the scan abutments, scanning, sending it to the laboratory, have the laboratory design or complete the design, because remember, they're not starting the design from scratch, they're just merging the data sets and they're finishing, you know, the let's call it discrepancy between the actual implant position to the final implant position. Everything else has been done. That's around 20 minutes for them. And so in design work, it's a 20-minute period of time. Then, okay, then it's approximately, for most of these restorations, 35 minutes in printing, and then you have the post-processing, which, you know, can take, it can take another 30 minutes even for the post-processing to cement, you know, to clean it, to cure it, to paint on a mask, to, you know, cement in the titanium copings. So it's approximately an hour and a half. So from the time, including scanning to delivery, right, the patient's ready to go, 90 minutes of time. Inside that 90 minutes of time, okay, is the finishing of the surgery. So the surgery, let's say, is finished over the course of the next half hour or so, or depending on how much grafting there is, the patient may be sitting, you know, waiting for that final restoration for, you know, 45 minutes, or it could even be, you know, an hour, depending how quickly the surgery was finished. But again, not manipulating the patient, you know, going inside their and in and out of their mouth. So, you know, for me, I think that's a big bonus for me and as well as for the patient.
One last question. Do you scan your full arch restorations?
So the answer is, okay, because this is a tricky one, and the answer is that we do, okay? Obviously, everyone knows that, you know, there's two aspects of it. One is the ease of scanning, of the actual technical procedure of scanning in a full arch, and then the relative accuracy of the scan and how you're going to manage that afterwards. And so number one, okay, two things. Number one, common to me as everyone else, scanning in a maxilla is relatively straightforward, at least as a clinical technique. In the mandible is where it can be somewhat more complex. The fewer implants and the greater the spacing between them are, and the less keratinized tissue, and the more the patient is salivating, the more difficult and frustrating it can become, where you may say, you know what, it's easier just to go ahead and put on some impression copings. We're fairly successful, okay, with going ahead and being able to go ahead and scan. And then from that process, you know, again, depending upon, let's call it the spread of the implants and the distance between the implants. And again, you see that I'm putting in 6 and 8 implants in an arch, so I have closer proximity of the implants. And by closer proximity of the implants, I believe we're also increasing the potential accuracy, you know, of these cases. It's what becomes a determination of what we need to do, if we need to create verification jigs and or what we need to go ahead and do. And there's some new processes actually and techniques that we're working with today, let's say not conventional, where we're scanning and not having to create, you know, secondary models. We're able to use that as a final model. And once we can go ahead and do that, we can create 2-visit restoration. So another time we'll go ahead and talk about that. This is a process that we're in the process of going ahead and working on. But once we have the exact design of a final restoration, right, and we can create an accurate model, we can go right to final restorations from the scan. So think about that, 2 visits to a final restoration, you know, in a full arch. But that's not, let's call it, everyday treatment.
Well, thank you so much, Dr. Klein, for your time and efforts. Please keep safe where you are, and we wish you well. And, you know, we hope to see you soon.
Okay, thank you much for the invitation, Saj. First of all, thank you for your patience in my extended time. I hope it was valuable and worthwhile. And everybody keep being excited about digital dentistry and learning about it. I think it's going to change the way all of us practice treating our patients.
Perfect.
Thank you.
Thank you so much. Bye-bye.
Bye-bye.